I'm going to talk about end-of-life care. And I want us to remember two words. So I'm going to say them now, and then I'm going to bring us back to them at the end of my talk. And they are, first, that we must be ambitious. And second, we must be humble. And in that I mean to make sure that at every step of the way, not just in this area but in all others, that we really do understand the patient and the family's point of view. Because we have an opportunity now. I see many faces in the room that I've met before as well as new people. We have done a great deal of work on patient safety in the Southwest in the last 6 years. And we are now in a new and opportunity phase to really build on that in a way that other parts of the country are just starting, so that we really embed patient involvement, patient experience, and the ambition for being truly excellent and continuously improving as we go forward, because we have a great foundation in place. First of all, is a fundamental truth that improving complex systems requires us to do the picture on the left, to join hands, to look together at the future, and to think ambitiously about how we can eradicate the gaps in our service and our communication. Whereas what tends to happen, not just in hospitals, but between hospitals and communities, and between even GPs working in the same surgery, and between all of us together, is we pick up our own little rucksack of ideas and commitments and disappear off in a direction different to everybody else. So if there's one fundamental principle that you, the 140, can get over to the other 9,000, and then the other 37,000 in our west of England, is this principle that changing and improving complex systems is not about doing our own thing. It's about doing things together. Secondly, is to turn the question around. We spend a lot of time as doctors and nurses and pharmacists asking people what's the matter with them. And that isn't the point. It's not the point now. It's what matters to you, the patient. Because most of our work is much more about long-term conditions, long-term management of people's lifestyles having to change to accommodate the illness that is not going to go away, but the illness that we can mitigate and improve their experience of the remaining part of their life as a consequence of our working with the patient and the family. So what matters to you? Now, end of life is a complex business. These are just 4 components of what we need to do to make sure that the last stage of someone's life is truly what matters to them. We need to recognize the probability of them dying, and that can be in the next few months, the next few days, or the next few hours. We need to be very sensitive about the way we communicate that, not just between ourselves to get the right emotion and compassionate activities in our team, but also with the individual themselves and their family and friends. And everybody needs to be involved in the decisions that are made. Everybody's needs are going to be slightly different, and so we have to, at the same time as having a standardized approach to end of life, we need to think about what the individual components of that need to be for this person in front of us. And then lastly, we need to do it. And the word reliability in my opening slide is very much pertinent to this. Writing it down, having the intention, is only part of the job. Delivering it is what needs to happen. Because as Dame Cicely Saunders, who led the world in thinking about end of life, rightly pointed out that how people die lives on in the memories of those who are left behind. So what is interesting is that we can be extremely creative and extremely thoughtful. Now, the Voices survey was compiled and put together across the system, the NHS, in 2012. And some of you may know your own situation with regards to that, and we'll look at that in a moment. But actually, that whole idea of asking family members, those left behind, what they felt happened during that end-of-life experience and what the quality of the care and compassion that was given actually was, that was all thought of in the 1990s. Not least possibly because at that stage the hospice movement had gained quite a lot of momentum and was becoming much more acceptable as part of the panoply of things that we have available to, not necessarily in the NHS, because it isn't always in the NHS, but running in partnership with the NHS. So I suppose my question is, you know, I think we must be afraid to ask how good we could be. And that's perhaps something that the South West can really take on board now, because we have many more tools and approaches to understand how good we are right now. And then we have to be ambitious about how good we actually could be. We can listen to the debates about the money. This particular subject is not just about money. It's about our whole approach to someone's last stages in their life and their family's experience of that too. So, thanks to the Health Foundation and the Nuffield Trust really working together on this in the last year or so, we now have some really good data. And it just typifies how the NHS can just be average. So, what we look at is the average across the whole of our country. NHS England, and we look at, well, you know, we've got a bit better at the numbers of people, the proportion of people who die in the place that they chose. So they're not whisked into hospital at the last minute when that wasn't their thought. They don't have facilities in their nursing or residential home, which is often their actual home in the last few years of life. They actually chose beforehand where they wanted to spend their last moments, and it actually happened. But we can now, thanks to the power of information, we can now drill down into this data. And what this data tells us here is that we, the South West, are that top line. We are already a long way ahead of enabling this than any other part of the country. That if we were to look across the south of England, for example at Kent, Surrey and Sussex, who are the blue triangles, they actually have a similar population to ourselves, although obviously in the north of that area have very young towns and urban areas, but their south coast is just like our south coast. They need our help. And if we were to look at NHS England as a whole, which after all is where the number crunching comes from and the comments about how much money we do or we don't need, there are places in this country which, for a variety of reasons, may never be able to achieve the sort of standard and care that we've achieved here. But they can surely learn from what we have managed to do in the South West. Whether it's visiting nursing homes, whether it's thinking really actively about the way we manage the hospital-community interface, whether it's about advanced care planning and having wider access to those choices that the patient made with their primary care doctor when they decided about the end of life. And so in ambition terms, we need to be even better than this. But at the same time, in order to tune our own ideas and thoughts, we need to share as widely as we possibly can. Or the NHS probably will run out of resources. So to go back to the four things that need to happen for the end-of-life experience to be both great for the patient and sustainable and compassionately delivered by us, the clinicians, we need to remember the maths around reliability. Now, this is a very boring slide. I show it a lot. But it never ceases to amaze me how much amazement there is in the audience when people recognize that they individually, or they're part of the system, can be extremely well delivered. Anne mentioned 95%. We can actually we have to all be better than 95% at each step to get anywhere near 9 out of 10 times perfection. And to get it almost reliably, perfectly delivered, which is an ambition worth having, we all have to be much, much better than that. Because every step reduces the chance of the subsequent steps having the right outcome. So this is another key principle that you need to get over to the 9,000 people that we all need to connect with and the other 37,000 people who are beyond them. We have to be more reliable in what we do. Otherwise, every day we will disappoint both ourselves professionally, but more importantly, the patients and their family members. Now, this is an absolute truth. Never believe that a few caring people can't change the world, because that is probably all who ever have. Now, here is a small group of people in the smallest hospital in the country, down the road in Weston, trying to work on a treatment escalation plan. End-of-care specialist nurses, one of whom is taking the notes on the whiteboard, consultant in palliative care, Julian Abel, some of you may know him. Foundation year 1, 2 doctors, and a core medical trainee, and a Quelker nurse, as we call her, one of the leads on the wards for end-of-life care. Meeting 10 minutes every week. Slowly but surely, we now have, I think we're probably now on our 10th iteration of the treatment escalation plan. Getting it right for us, but also for the patients. Not writing down what we're not going to do, thanks to a patient who overheard somebody going through the form with another patient and said, "Why don't you tell me what you are going to do for me when I'm dying, rather than list all the things you're not going to do?" So we've changed it round. He had a very fair point. So, systematic approach. What have we done as a result of the work that Anna has been doing? We've used the end of life, the new concepts and framework that's taken over from the Liverpool Care Pathway. We have used that to, as a case to train medical directors across the southwest. So this isn't just a West of England thing, this is running across the southwest geography. And we've run 2 sessions. We had about 25 medical directors at each, and got them to understand the methodology that many of you in the room are totally familiar with, the whole idea of improvement methods. We're now running sessions for the end-of-life leads across the patch. Again, going very much into the detail of the methodology, but also getting them to work on the areas that they want to improve within their own jurisdiction. A whole variety of things, each of which fit into the groupings that I gave you earlier. And the intention is for those individuals to come back in September, and then we start sharing, as many of you will be familiar with, the whole idea of a World Cafe, where you tell each other what you've done. Everybody learns very quickly what they could do as well. This is being sponsored by another organisation that has been invested in to improve quality across the system. And we're using this resource in a consistent way with our own approach in patient safety. Models for improvement, PDSA, measurement for improvement, ongoing, peer connections to get people sharing ideas, and ensuring that through the medical directors that management and leadership is in place. And then we'll be recognizing and celebrating the work done. So the next principle to get over to yourselves and the others outside of this room is, unless the leaders understand what you're trying to achieve, unless the professionals are all working together, may not literally be holding hands, but the whole idea is that we're working together, and unless we work in partnership with patients and families, we won't get this virtual improvement and cycle of continuous improvement that we all seek to achieve. And you need to remember that back at base, whatever the project that you're working on. Many of you will be already familiar with the whole idea of looking at the system, the processes that are going on now, how it varies many of the human behaviors that are often organized against quality rather than for it, not deliberately, but just because that's the way the system has evolved over time. And we are all invariably full of ideas as to what could be done about it. But the key thing here is, in your organization, in your GP surgery, in your community hospital, or in one of those huge, great acute hospitals, is there will be the innovators. There will be those early adopters of the idea, the enthusiasts, and probably we're in the room today. Back at base are the others. They are, in many cases, challenged to work out how this is relevant to their job. Well, you can emotionally engage with them, not least in this particular subject area of end of life, but they will struggle to understand how they're going to do it, reflecting on the Lego model, because they're already busy. And we have to find all sorts of imaginative, constructive, simple, step-by-step ways to jump that chasm that exists between us, the early innovators and adopters, and the others. And then we also have to be mindful of the rather rude and disrespectful term laggards, but these are often the people that really see the problem with what we're trying to do. And if you can engage them, at least in the conversation, and acknowledge some of that in your measurement strategy, you may end up with some extremely powerful converts. Laggards, numerically, are the same number as the people who are the early adopters and the innovators. But we must not allow those skeptics to undermine the work we have to do. You're all familiar with the whole driver diagram concept. Call it a conceptual framework. It doesn't matter what the terminology is, but the point is that there isn't a simple fix to any of this stuff. This is around, again, looking at handover to ensure that end of life works well for a patient. And what we see on here is that all sorts of things have to happen. There'll be some things that jump out. We've already heard about SBAR. But there are also other things around running meetings, about respectful of priorities, about making sure the important information is first. We don't bore the pants off the people that have come to the meeting and then they have to leave when their bleep goes off, unknowing of what the intention is for the next test. We all know how to record PDSA ramps, the idea that you're slowly building an understanding of what works and also of what doesn't work. And that here, this was around how the junior doctors could start the process of flagging up that this time, this patient really didn't want to come into hospital. They wanted to have a conversation about their last phase of life, and we were denying them the opportunity by just walking past the end of the bed. And how do we make that happen as part of our ward round in a respectful and constructive way, and how do we work with the nurses to make sure this is then followed through when they're discharged home so their primary care team can take it on board. The family of measures, the fact that we can't just measure one thing, even though NHS England would be absolutely delighted if we could just measure one thing and then they could measure it on our behalf. So the idea that we need outcome measures, in this case where the person dies and is it their preference. We need process measures, and we also need the balancing measures. And sometimes the source of those can be those skeptics at the far end of Roger's diffusion curve. So, just to bring this to a conclusion, this was the map of the Voices survey in 2012. And as ever, red is bad, amber is could do better, and green is good. We know in improvement science terms that that sort of RAG rating is not what we need. However, you can see that we in the southwest at the bottom were already pretty green. We could rest on our laurels. But I'm suggesting that we don't. And I'm telling you that actually there are already teams working very hard on building new driver diagrams and new conceptual frameworks and new ideas. And that's great. Because at the end of the day, it is the patient's experience and their family's experience that matters most in this regard. And if we can get this right, we will have made a big difference to the quality of the care that we deliver for patients. And almost certainly a big difference in the amount of money that we spend on it. Because every patient who dies in their place of preference, and not a hospital, because most people prefer to die out of a hospital, saves the South West just under £3,000 in money, at the same time as having an optimal experience. And that must be the best win-win situation for us all. So, to reflect, let's be ambitious, whatever the subject area is that you're working on. There will be people out there that know or are doing things that we've not tried, and we need to know that and get on with it and see if it works here. But at the same time, make sure that we always involve the patients and the families, because they will tune our thinking and tune our services so that we absolutely deliver what matters to them, rather than just what matters to us. Thank you.